Good afternoon and good morning to you here on the West Coast. My name is Jose Leon, Chief Medical Officer for the National Center for Health in Public Housing. Thank you for attending this webinar series exploring cultural competence and humility in the care of HIV patients. We are very pleased and honored to have a great speaker, a great subject matter expert presenting this for the National Center for Health in Public Housing. We are very proud to have this partnership with a Southern AIDS Coalition. Before we get started, we have some announcement and some information from the National Center for Health in Public Housing. We are funded by HRSA to provide training and technical assistance to community health centers, specifically those serving public housing residents. We do this through a national cooperative agreement through HRSA, and this is the National Center for Health in Public Housing provides training and technical assistance, research and evaluation, and outreach and collaborations to all health centers serving public housing residents. This is a live activity, so everybody is muted, and if you have any questions, we are going to have a Q&A session at the end. You can either type your question in the chat box or use the raise hand icon and your line will be unmuted. And before we get started, we have some information about the demographics and social determinants of health affecting public housing residents. There are around over 2 million residents living in public housing. The average household is 2.2 persons. Most of, or at least 38% of those living in public housing are children under the age of 17, and 50% of those living in public house, 59% of those living in public housing are female. 55% of them have less than high school diploma, and over 83% are below the federal poverty line. There are 107 health centers funded by HRSA to provide training and to provide services to public housing residents. And over 356 or almost 356 federal qualified health centers reported providing services to 4.4 million patients. The 107 public funded by HRSA public housing primary care or PHPCs provided services to over 800,000 patients in 2018. The traditional public housing model as we know it is diminishing, and you see the number of units and the number of those living in public housing, the number is decreasing. However, the health needs and the social determinants of health affecting these populations remain the same. So it's more difficult for health centers to provide services to these vulnerable populations. There is a great need of working with community organizations and partner with them to make sure that we are including all those who are having public housing, housing issues or housing instability in the community. As a brief introduction, most of those living in public housing are affected by chronic medical conditions. These numbers are taken from a HUD publication, a health picture of all assisted adults. And if you see most of those, or at least when you compare public housing residents with the population, the average population, they tend to have a higher rates of chronic conditions such as diabetes, asthma, COPD, and obesity. Now, in regards to HIV in public housing primary care patients, in 2018, and this is the latest data, 4,347 patients received services in public housing primary care clinics, and over almost 90,000 of patients were tested for HIV in 2018. This is data taken from UDS as well, and in 2018, in regards to sexual orientation, 46% of patients said that they were straight. However, there is a high percentage who responded, specifically 43% responded that they don't know, which, as we are going to discuss, there is a lot of stigma in the population, and sometimes they are afraid of disclosing sexual orientation. So I would like to introduce our speaker for today's presentation. Marrecos Harris is a Tennessee native, but currently resides in Birmingham, Alabama. He has public health background that spans over 8 years. Marrecos is a graduate of Tennessee State University in Nashville, Tennessee, with a degree in interdisciplinary studies, and his areas of concentration were English and religious studies. He began his career in public health with an emphasis in HIV with the Emory University School of Medicine's Hope Clinic in Atlanta, Georgia. At Emory, he served as a clinical research interviewer and retention specialist for the HIV Vaccine Trials Network 505 study. It was this job that sparked a real passion for Marrecos and ultimately gave him the assurance of the career path he wanted to pursue and mature in. From that time, Marrecos has worked in many areas of the HIV field, including community, state, regional, and national organizations. Marrecos has had the privilege of serving as outreach coordinator for the Haven and the PrEP director for the Tennessee Department of Health in Memphis and Nashville, Tennessee. He has worked as a senior program analyst for the HIV, STI, and viral hepatitis team with the National Association of County and City Health Officials in Washington, D.C., and he currently serves as the senior manager of capacity building assistance with the Southern AIDS Coalition. Marrecos finds his greatest joy in working directly with the community most disproportionately impacted by HIV and helping to elevate the voices of those who oftentimes are overlooked. Without further ado, I would like to turn it over to Marrecos. Good afternoon.
Good afternoon. Again, as previously stated, I am Marrecos Harris, Senior Manager of Capacity Building with the Southern AIDS Coalition, and I am super excited and a little nervous as well about presenting today. This training that we've been doing across the Southern United States has typically been a 4-hour in-person training, so I'm excited that you all are kind of stretching me a little bit to kind of see like how we can diversify how trainings are shared among people that are interested in learning about serving people from a culturally humble place, a more competent place, and so I'm super excited about that. Today's discussion is going to be high level, but we will talk about some specifics. But it's really just to talk about some strategies to really introduce cultural humility, what cultural humility is. We're going to pull in a little bit of stigma, how stigma shows up, what stigma looks like, how we sometimes don't even recognize it. We're going to talk through some things, and in some of the places where I would typically do activities, I'm going to just kind of talk through those and show some pictures and slides so we can kind of get an idea of what that is. This here is me doing my welcome and saying hello to you all. So again, thank you all. I'm super excited, and I'm looking forward to any questions that you all may have at the end. Before I get started, just wanted to talk a little bit about the Southern AIDS Coalition and our partnership that we have with Gilead Compass Initiative to really talk through how we're able to provide these trainings and also offer you all the opportunities to request the trainings if you want to have these trainings done in person, to where we come to you and kind of work it so you can have the full experience of going through activities, going through the different assimilations, etc. So Southern AIDS Coalition, we were founded around 2001. During that time, a lot of attention was not given to the Southern United States as it pertained to the HIV epidemic, but we realized that a lot of things were happening here to where we needed more attention. So it really started out with a bunch of advocates, some health department folk, looking at the policies, looking at Ryan White programming and what that was, and how it showed up. And from that time, we have moved into really not just doing advocacy work, but we now do capacity building assistance. We do leadership development and education, which is a program that we do for people living with HIV to kind of teach them how to advocate for themselves, teach them how to disclose properly, teach them how to create their own narrative, tell their own story, teach them how to be educators so that people have a better understanding of what it is to live with HIV and thrive with HIV. And it's really just to empower people. We do intersectional advocacy, and that is advocacy that pertains directly to HIV, as well as those things that may not be direct issues of HIV, but they intersect and they correlate, i.e. housing, food, those types of things are what we deal with. We do research and evaluation where we partner with Duke University to really kind of create some studies and give us some data and do some real-time information to share. We do things around stigma. We do more population-specific things. We also do strategic grant making to where we do funding for organizations up to $100,000. They are transformative grants, and it is around organizations, health centers, government agencies that in the South, particularly the South, that want to create stigma interventions or stigma programming, or to support stigma education to kind of decrease stigma, call stigma what it is, which is stigma, address it, figure out how it's impacting the persons that we're serving, figure out how it's impacting the people that are on our staff and that are on our team. Then we have small grants, which are Spark grants up to $25,000, to where you really get to create these community campaigns, community-led campaigns to communicate whatever message that you choose to communicate, with the undergirding of that this message will ultimately kind of eradicate stigma. It'll lessen stigma. It'll bring knowledge to communities, etc. So and our partnership, a lot of this we're able to do through our partnership with Gilead. The Competence initiative was launched in 2017, and it was really a response to the HIV/AIDS epidemic in the United States, the southern United States. And so Gilead has made a $100 million commitment to the southern United States over the next 10 years. Of that, they chose 3 coordinating centers to head up this work, with one being the Southern AIDS Coalition, the other being Emory University School of Public Health, and the third being the University of Houston School of Social Work. So we have this collaborative strategy that we're trying to do, to where we all have different focus areas. Emory is working on organizational capacity, building the infrastructure for sustainability of organizations. University of Houston, my apologies, is working on trauma-informed care, substance use, and those types of things, mental health. And then we are focusing on stigma reduction, like stigma reduction, cultural humility, how to create programming to make our facilities more accessible, more welcoming, etc. So everybody has their own lane, but through the collaborative strategies that we're using, we're able to kind of work together and bounce off of one another. So that is really what we're doing through our partnership with Gilead. And just, I talked through it, but I wanted to read it verbatim, the vision of Southern AIDS Coalition. So we envision a South where every person has access to high quality health care and essential support services free from stigma and discrimination. We also envision a South where every person understands his or her risk for HIV transmission, receives routine screening, and has access to a full range of prevention, interventions, and harm reduction services. We absolutely believe, while a lot of our work actually deals with persons living with HIV, that prevention is just as important as care, because we want to make sure that we're covering the full gamut of opportunities to help kind of decrease what HIV looks like, to change the narrative around HIV, and to kind of move that needle on new cases of HIV. So that is a bit about SAC, the Gilead Competence Initiative, how we're able to bring this training to you. I know that was a mouthful, but now I'm going to actually move into what you all have me here to do. So our objectives, and what you'll realize is that there are going to be varying sets of objectives that we will go through as we move throughout the training. So I'll introduce a set of objectives, and we'll talk about some things, go through some things, and then I'll introduce a new set of objectives, and we'll also do similar things in that regard. So our objectives really are just, we're going to describe how the dynamics of identity, perception, and perspective really shape culture. We're going to discuss how identity, perception, and perspective impact workplace interaction and service delivery. And jumping right in, the first thing that we have here, it says perspective versus perception. So we can see 3 different shapes, and one says this is true, the other says this is true, and then there's that middle shape that said this is truth. A lot of times when we work in organizations and facilities and healthcare places, what we see as individuals, what we see as persons working in the lanes that we're working in is the truth. It is what is true to us. It is what we know, what we believe. And then somebody else on another team sees a thing and it is true. That is their experience. That is what they see. That is how they function. But then there is this thing, the truth, right? And the truth is the full picture. And first step that we want to start to deal with is like when you are creating an organization and you are trying to become more culturally appropriate, culturally humble, create a space that is non-stigmatizing, we have to recognize that my truth is not the only truth, that there are multiple truths, and it is the job of us as service providers to understand the truth of other persons. So we have to move around the full shape to get the full picture. And I know in busy environments, we don't have a lot of time to learn the complete job description of someone else or learn everything, but it is a responsibility that we should take to kind of gain enough information of each of those roles so that we're able to get a full view of the picture. Because when you move to the space of truth, you understand that what your truth is could potentially be impacted by in a negative way by not really understanding another person's truth. So sometimes it requires us, we have to become comfortable being uncomfortable and come out of our spaces to kind of get a full view of the picture, to get a full view of what we see, to get a full view of how things are working. And a lot of times we don't do that because we will have individuals that will come into our office, fill out a bunch of paperwork, go through a bunch of programming, go through a bunch of talking, and then we'll send them to the next person, and that person will go through a bunch of questions, go through a bunch of scenarios, go through a bunch of things, and the client becomes exhausted because they're being asked the same thing over and over and over again, when if we kind of communicated a little more, we could create processes that were a little easier on clients to make those experiences ones that are not necessarily cumbersome for the provider or the client, and then you can get to a truth from an individual, because it requires us to develop relationships with those persons we see, and the people that come in cannot just be a number. They cannot just be another client. They cannot just be another person living with or impacted by HIV. We have to humanize those individuals. And a lot of times people are like, well, this is for you. We're doing this for you. So why aren't you telling me the truth? But because of stigma and because of life circumstances and situations, sometimes a person does not feel comfortable being completely honest because they don't know how they will be judged. They don't know what reaction their provider will have. In the line of work that we all do, we talk about sex a lot of time, and lots of people are having sex. There's lots of sex going on, but our body language will prevent people sometimes from sharing what needs to be shared. So that is about perspective. That is about perception. And a person's perception is their reality until there is something that happens that proves that that reality that has been perceived is not really the truth. So I know that's a lot of plays on true and truth. So hopefully that was not confusing. So what I'm going to do next is move through a series of pictures just to kind of talk through what this perception, what this perspective, and what is true is looking like. When you see this picture, if you were in person with me, the fun thing about this, you would have gotten this picture in a lot of little pieces, and you would have had to put it together as a team to create a bigger picture. And the dialogue would have gone for you to try to guess or put together what it is that you're looking at while you're putting it together. So the full picture shows an elephant, but you have a bunch of folk with white coats and a lady with a suit on, and they're all blindfolded, and they're filling different pieces of the bigger picture. And one person feels and says it's a spear, another person says it's a fan, another person says it's a wall, it's a rope, it's a snake, it's a tree. But the thing about it, they're all blindfolded so that they cannot see clearly what it is. So vision is impaired. You only are dealing with a certain piece of this puzzle, a certain piece of this situation, a certain piece of this client. And a lot of times we deal with clients in pieces versus dealing with clients as a whole. So these persons, when you put it all together, they make up a complete picture. And one some of the first steps around cultural humility and cultural competence is to get the full picture. We cannot adequately serve a person when we're only dealing with them in parts. If we only deal with an HIV diagnosis, but not deal with the other social determinants of health that individuals are experiencing. If we only deal with an HIV diagnosis, but not dealing with that this person is impacted by a housing situation, that this person may have food issues, if we think that they don't want to take medicine, but really their priority is, I don't have anywhere to store my medicine that is safe for me, I don't have anywhere to live, etc. So you have to deal with the totality of a person. And I'm going to go through these next ones really quickly because time is moving, and I thought with the time that we had, I'd be like, I wouldn't have enough time to fill in, but apparently I'm a talker, and it appears that time is moving. The next thing, people sometimes will show up and it appears that they're all over the place. It appears that they are not showing up the way we expect them to show up or the way that we feel they should show up. So this language here, we see it, and the crazy part about it is, while it is jumbled up, while it is not how we would imagine it to be, while it is not shown up in the traditional way that we think clients should show up, we are able to really look at this and still determine the message. When moving into a place of being culturally humble and being culturally competent and being non-stigmatizing, even if the person shows up in a way that is different than we expected, that is different than what the last person was, that is different than how the last experience was, because we still have the ability to read it. It may take a little extra work, it may take a little more focus, but we have to not put people in boxes and realize that while they show up, I still know that this says, according to research at Cambridge University, it doesn't matter in what order the letters are in a word are. The only important thing is that the first and the last letter be at the right place. The rest can be a total mess and you can still read it without a problem. This is because the human mind does not read every letter by itself, but the word as a whole. That again moves to how we should deal with the person that we are serving. We should deal with them as whole individuals. We should deal with them as whole people and not just partial persons. And we have to move away from just dealing with the person as a diagnosis, as a medical chart, as a number. And so that is what we have to do. And this is another thing I'll skip through, and another thing. So fact and perception, right? Fact and perception kind of goes to what we've already talked about earlier. Perception is really a mental impression, a way of regarding, understanding, or interpreting something. Our mental impression is informed by facts and stories. And then our stories arise out of our experience and expectations. Careful and critical examination or awareness of the expectations and experiences that shape our stories can increase our objectivity and confidence in our perceptions. So when we deal with like facts and stories, we can kind of really look at, like, from the emergence of this HIV epidemic, we can look at the history of HIV and how many things that were out that were non-truths at the time, and they were really fear-based and they were not based in fact. But as we are able to look at what the science is doing, what the experiences are now, like, we can do more things based on facts, so that the stories that are told and the narratives that are shared are not built out of fear, but they're built in fact. They're built in science. They're built through lived experiences. Because of these things that are facts that are built out of fear, we are still experiencing stigma in a lot of areas. And for us to be able to move to be culturally competent, culturally humble, culturally appropriate, we have to deal with stigma, how stigma shows up, what stigma is doing, what stigma means. So stigma still shows up, you know, and I really want to deal with taking a definition of like, what is stigma? Like, what is stigma? We all feel like we know stigma. Right now, stigma is a buzzword. Just like we have many buzzwords, stigma, intersectionality, those types of words, they're buzzwords. But a lot of times, if we would just step back and really look into what this means, you know, because stigma still continues today to be a persistent barrier. It's keeping people from coming into care. It's keeping individuals from staying into care. And it sadly sometimes prevents people from receiving good or quality care, because sometimes we bring stigma and stigmatizing behaviors into the clinical experience or into the experience of our clients, and it shows up and they can feel it. So when we look at what stigma is, right? Stigma is a process through which we, society, create a spoiled identity. For an individual or groups of individuals, we identify a difference in a person or a group. Let's talk about like physical disfiguration or behavioral difference, people assumed to be promiscuous, and then mark that difference as something negative, as a sign of disgrace. Identifying and marking differences as bad allows us to stigmatize the person or group. Stigmatized people tend to lose status because of these signs of shame, which other people regard as showing they have done something wrong or bad or sinful or immoral. The reason the word I like the most around that is spoiled identity. Most times stigma shows up when something different than what we believe is our norm shows up. When something different than what our beliefs are, when there is something outside of who we are, how we believe a thing should be, how we believe a thing should move. So anything outside of our identity, we tend to look down on, and that is a spoiled identity. So that is really the definition that we tend to use around stigma. Is really gives us a look differently at it, and we call it like anything different from my identity, because my identity has to be the correct identity, right? What I associate with is typically what we feel, but it closes off the space for us to accept differences, to accept people showing up in spaces differently. Stigma has had a persistent impact on the course of the epidemic. The challenge of stigma can be addressed through cultural competence and humility. And the deeper our understanding of the challenge, the better equipped we will be to address it. We can't address something that we choose not to understand. We can't address something that we choose to not deal with or to pretend that it doesn't exist. We cannot be culturally competent. We cannot be culturally appropriate. We cannot be non-stigmatized if we don't choose to identify stigma, name stigma, call it what it is, and then figure out methods and strategies of how to lessen stigma and ultimately eradicate the stigma that prevents people from coming in to get care, stay in care, or to receive quality care. Next set of things that we're going to move to is, so we want to name some factors that shape individual identity. We're going to define intersectionality as it applies to identity. We're going to talk through some interpersonal dynamics of identity. And if we were in person, and I'm putting this on there because I want you to kind of do it as you think about these things, and if you're taking notes, we're going to strategize behaviors to mitigate the negative dynamics of identity. So we want to move into how people really show up into these spaces, how people come in, and we kind of forget that people come in multiple pieces, as multiple parts. There's a thing that we deal with sometimes, the ecological model, that really, there are lots of layers to people. There are lots of things, there are those intersections. So personal identity is really dealing with like the biology, the culture, the ethnicity, and the lived experience of a person. You know, so personal identity, that's really the concept you develop about yourself. It evolves over the course of your life. It changes, you know, you come into more self-awareness, you come into different experiences that shape how you feel. And, you know, those things, those personal identity really includes like the biology. Those are the traits you genetically acquire. And I know I have to say this because I'm talking to probably a bunch of service providers and a bunch of physicians, but just indulge me momentarily. Culture is, you know, a way of life developed and shaped by a group of people that could be passed down through generation and generation. That could be tangible things like food types. That could be something tangible like clothing or quilting or different behaviors, patterns of human behavior such as social customs, as values, institutions that are range from religious to political to professional to social groups. And then ethnicity, cultural heritage shared by biological or related groups. And then the lived experience. All of these things they're things by themselves, but then the lived experiences kind of also can alter those things outside of biology. They can alter those other things that happen. You know, lived experiences, the way all of the above that was mentioned comes together, and it's the unique shared events. So lived experiences could be the birth order, it could be the family size, it could be experiences with families, experiences with friends, experiences with the workforce, experiences with medical providers. That lived experience will impact all of those personal identity beliefs. And it speaks to us being layered individuals. And then we move into intersectionality. So intersectionality, there are a lot of pieces here. Like there's race, there's economic status, there's sexual orientation, education, HIV status, gender, ethnicity, incarceration. And this list is not exhaustive by any means necessary. So while you look at this particular slide, incorporate what you think belongs there. Incorporate your personal things that make you who you are. Incorporate those different intersections that play into your lived experience. And intersectionality defined by Kimberly J. Crenshaw. She was a Black feminist, a civil rights advocacy, and this is where that intersectionality talk really comes from. We use it in the field oftentimes when we talk through it, but a lot of times because it's the word that is being used, we don't really know the behind of that word. And Kimberly Crenshaw, a Black feminist, a civil rights advocate, she was a pioneer that was in critical race theory, and she helped open up the study behind a double-blind face victim when it deals with racial and gender prejudices. So intersectionality was really built out of prejudices around gender, around race, about being female, around being Black female. The definition of intersectionality is the complex and cumulative way that the effects of different forms of discrimination, such as racism, sexism, heterosexism, and classism combine, overlap, and intersect. So I will use that again. So intersectionality is the complex and cumulative way that the effects of different forms of discrimination, such as racism, sexism, heterosexism, and classism combine, overlap, and intersect. That is the definition of intersectionality. And those are the things that we have to be mindful of in dealing with persons. That is not to negate who you are. That is not to negate how you are made up, but it is what we should consider when trying to move to a space of providing culturally appropriate and non-stigmatizing care. That discrimination a lot of times is at the core. And we look at discrimination as we only look at it from a race thing. We only look at it from a Black-white thing. We only look at it from a better than or less than thing. But discrimination can show up in really small ways. Discrimination can show up in ways that people eat. You know, your food is different than mine. You cook things different than I do. So I think a lot of times we have this big, robust definition of what a thing is, and we only think of these things in huge entities, but sometimes the little small things is what really makes it real and brings it back around. So what happens here is when we're dealing with individuals in this intersectionality, we're going to talk about some core dynamics, you know, some things that show up, like that make us who we are. And this portion would also be activity-based. And I keep saying it's going to be activity-based because maybe you will go after this to SouthernAIDSCoalition.org, look at the trainings and request the training so that we could potentially come and do this in person and actually build some strategy, build some action plans, and build some realistic goals on how to help us all become more culturally appropriate and non-stigmatizing. So the first dynamic when dealing with people, and these are really just about how people will show up or how we look at people or how we feel about people, is seen and unseen, right? So seen and unseen, what we see is only the tip of the iceberg of an individual's sense of identity. Most of what makes up our sense of identity is what is unseen, cultural, ethnic, and lived experiences. So to know and understand who someone is requires that they let us in. It takes rapport. For people who anticipate a stigmatizing response, This is difficult if they think others might be uncomfortable or reject that part of their identity. When dealing with clients, we only see a piece of them, and vice versa. When clients deal with us, they only see a piece of us. And a lot of times decisions are made based on the iceberg experience, based on the tip of the iceberg experience. And in treating people from a culturally appropriate, non-stigmatizing place, they have to be made comfortable. They have to be made to feel like they belong there. They have to be made to feel like that they're in a partnership. They have to be made to feel like that this is my healthcare and you're a part of my healthcare journey and you're going to help me to reach those goals. So we have to include them to make them so that they can own a part of their healthcare journey and not just serve them from a place of only what we see, the iceberg, or only what is checked off on those intake forms, or only what is the HIV delineation of an individual. Another dynamic that makes people who people are the personal, social, and political histories with people can cultivate general relations about others with a group identity. Worse, it can support stereotypes and prejudices. We're in a day and time now that party affiliation when it comes to politics automatically creates a lot of assumptions. Party affiliations when it comes to elections locally, nationally, they create a lot of assumptions, and it negates that there is history, that there could potentially be story to why a person believes what they believe. And we move a lot of times based on a piece of a story or a piece of a history that we have from a person, and we make full decisions about them. We make full assumptions about them. And that's not fair. That's not right. There is the in-group and out-group dynamic. It is human nature to form social groups. Social grouping creates lines for inclusion and exclusion. When threatened by differences, people can resort to in-group and out-group scripts to understand what is going on and to feel comfortable and safe. We have to understand that when we are medical providers or clinicians and we deal with people who are not medical providers, we have to be careful not to create a dynamic that is like this. It is like high school cliques or sports teams and the fans, or religious affiliation, that there is an in-group and there's an out-group. This is my group, this is your group. And if we create spaces in our service organizations, people will feel that there are differences, that there is you, there is me, and it's not a partnership. We have to create partnerships with those that we're servicing. And that doesn't mean go out of your way and create this whole, robust plan, because in serving clients, I do realize time is of the essence, and there are limited times a lot of times to do things. But it does say that we have to be intentional about creating atmospheres and creating spaces to where the persons that we are serving feel like they're in a partnership and do not feel like that they're in a situation where they're being done a favor. Anxiety and triangulation. That's the fourth dynamic of how people show up. Their social anxiety can be difficult to hold. It is natural to want to discharge that anxiety. People often do this by talking to a third party or their experience to release anxiety. It can be helpful and instructive to process with someone outside of the anxious relationship. It can also be hurtful if the intent is not to understand the situation, but set out to make the other person the blame. A lot of times when we talk to one another, or we've had experiences with clients, or clients have had experiences with us, it may not be helpful to go and to talk to someone who's had an experience with that client to really get somebody on your bandwagon, or you need somebody that will actually talk you through and say, hey, well, what are additional options for us to go through with trying to service this individual? What could we have done differently, or what could that individual have done differently, to where maybe the next time they come in, we can provide some coaching to say that in this partnership, in this working relationship, this is how we should move, or this is how we should do. When this happens and it makes you feel like this, I want to create a space to where it's open for you to share with me as a client that this made you feel like that, or the way I said this, or the language that I used was stigmatizing or not appropriate. And I also, as a provider, want to create a space where I can share with you that, hey, I asked you to do this because of X, Y, and Z. Is there a way that I could have communicated that differently? As providers, we need to have more than one way to communicate. We need to have more, like multiple sets of language to be able to navigate the patient or the client experience. Everybody shows up differently, so we have to be continuously in a posture to change, continuously in a posture to move. False conclusions: when significant differences arise between people who do not know each other, well, they can attribute the difference to visible identity traits rather than more complex reasons that require a discussion. Let's not make false conclusions about the persons that we serve. Let's not make false conclusions about where people come from, and vice versa. We should be creating environments so hopefully our clients are not creating false conclusions about who we are and how we serve them. Dynamic 6, there's intent and impact. The intent and impact of our actions are not always one and the same. When someone says or does something that is hurtful, we tend to assume it was on purpose rather than unintended. Most people act with good intentions, but we stumble, and the impact of our actions don't always align with our intent. Ouch, ouch, and oops are social contracts. So the fun thing about that, so I call it the kids game. So if I'm offended, I may say ouch. If you offended me, it's basically like a oops, which means you acknowledge that you offended me and you allow me to say that I'm hurt. And I allow you the response to say that it was unintentional, and then it can become a teachable moment of like, how now do we move from that? I said something that was hurtful. I said something that was stigmatizing. I give you the space to call me on that, and now hopefully you in return extend to me the ability to apologize and to figure out a better way for us to move forward. So bad situations should always, if possible, be tried to turn into teachable moments so that we can have better experiences with those that we're serving. Perception and reality. I think we talked about that enough earlier, so I'm going to continue to move from that. Dynamic and mindset. All of the dynamics can create social and unconscious biases. Our society has a long history of attributing values to groups of people as better than and less than. These are often accepted and unchallenged social rules that can shape our thoughts and behaviors. When we talk about the mindset and biases and the better than and less than, it really moves into value system. Sometimes we overvalue things and we undervalue other things. When we look at undervalue and overvalue, how we look at that is men versus women. A lot of times society gives more value to men than they do women. Trans folk versus people who identify with the sex that they were assigned at birth. We give more value to cisgender people. Cisgender means that the doctor assigned you a certain gender at birth, and that is the gender that you acknowledge, that is the gender that you recognize yourself as, versus trans being a gender that you opposite of what you were assigned at birth, because you believe, you feel, and you know that you are a different gender. We overvalue and undervalue. We do black versus white, gay versus straight, educated versus lack of education, certain statuses, and that's what we do when we have those different mindsets. In summary of all that I just said, it's really, so don't spend our time trying to make other people wrong just so we can be right. Listen to understand, appreciate, and validate. These are quick things that we can think of to kind of help us in moving towards being more culturally appropriate, being more culturally competent, being more non-stigmatizing. Listen to understand, appreciate, and validate. Speak with the intent to be understood. Say it more than one way. And I remember I said earlier, it's the little things, it's the little steps. People recognize them, people see them, and they see when you're trying. Recognize underlying emotions, yours and theirs. Some days we just have bad days. Some days things did not go right before we left the house, right? And we have to understand that about our clients as well. Some days things are just not the best. So we have to recognize those underlying emotions, be intentional about picking up behaviors that are different than the norm and not typecasting someone based off of one experience. So we have to operate with forgiveness. That goes with the ouch and oops. Demonstrate inclusion when there are in-group and out-group dynamics. Recognize your better than and less than biases. Recognize how you prioritize what is good, what is bad, what is good, what is great, etc. And make sure that's not showing up in those experiences with clients. Learn about people from different cultures and ethnic groups, but don't forget to know the individual. A lot of times when we talk about cultural humility, we want to learn, you know, the big things, and we still mess it up when we look at a culture at large and forget that this person is an individual within a culture at large. So I must also get to learn and understand the person as well as the culture of the person. So now we will move into, hopefully quickly, into compare and contrast of cultural competence and humility. We'll describe the impact of cultural competence and humility, and develop, and we'll talk about individual and institutional strategies for creating culturally competent and humble environments. Just a little graphic. So operationalizing cultural competence and humility. Cultural competence and humility requires that organizations have a defined set of values, principles that demonstrate behaviors, attitudes, policies, and structures that enable them to work effectively cross-culturally. So it's looking at what is the value system of this organization? What are the principles of this organization? Our behaviors, our attitudes, our policies, our structures. What does the waiting room look like? Does the literature that we have represent the population that we serve most? Does the pictures that we have on the wall look like the communities that we are serving, look like those communities that come in to receive services from us? Is the front desk welcoming? Is it warming? Like, what is the experience from the front desk to the back? We should also have the capacity to, 1, value diversity. 2, conduct self-assessment. We should always be assessing ourselves. We should be able to manage the dynamics of difference, acquire and institutionalize cultural knowledge, and 5, adapt to diversity and cultural context of the communities that you serve and the colleagues that you work with. I think it's important to call out the colleagues that you work with, because if you cannot respect the cultural differences and the context of the people that we work with and that we are on the same level with, for lack of better words, then it will be a difficult task to be able to operate in cultural competence and humility with those that you serve. You have to be able to extend these same principles, to extend these same courtesy to those that you work with on a daily basis. I think that is where the best experience comes from, because if I can extend these cultural humility and competence to you as my colleague, it's easy to now extend those skill sets to those persons that we are serving that come to our facility. So we have to also incorporate the above in all aspects of policy making, administration practice, service delivery, and involve clients systematically when possible, key stakeholders and communities. A lot of times we try to answer these problems of cultural humility and cultural competence and how to make our facility better with the same people that are in the facilities that are sometimes the root of the problem, but you have those persons that you are serving, those persons that are most disproportionately impacted, allow them, identify champions within your facilities, identify folk that are model clients, for lack of better words, and then some that are not so model clients, to help you create policy, to create things that will make your facility better for service delivery. So I always tease, like, we create studies for people to participate in, and then when the study doesn't work, we're like, this was going to be a great study, this was going to be amazing, why didn't this study success? Why wasn't this study a success? And then you look back at the genesis of the program, or the beginning of the program, where the infrastructure was built and the data was what we wanted to collect and what we wanted to answer, and it's all the same people, and none of them include the person that this study or this research project was supposed to impact. So we went into it without meaningful inclusion, of persons living with HIV, without meaningful inclusion of persons who are of those populations that we want to better serve. When we talk about cultural humility, it's an evolving and a dynamic process that takes quite a bit of time. It will not happen overnight, but SAMHSA has created like a cultural competence continuum. And there are multiple things. So cultural destructiveness, cultural incapacity, cultural blindness, cultural precompetence, cultural competence, and cultural proficiency. The goal is cultural proficiency, but I think our service delivery areas will become a lot more effective and have a lot more uptake in positive care experience if we really get to that cultural competence piece. Cultural proficiency would be shooting for the stars, getting through the stars, and moving into the universe. Cultural competence is actually hitting those stars, I believe. And again, SAMHSA has more information on that. I'm going to keep moving because the time is moving, but I'm going to give definitions really quickly of what these different definitions are. And hopefully you'll listen and you'll kind of take a look to see like where you are, where do you see your organization in this, where you are as an individual in this. So cultural destructiveness is this stage is characterized by attitudes and practices, as well as policies and structures in organization that are destructive to a cultural group. Are there things in my organization or in my healthcare facility that are potentially damaging or destructive to a cultural group? Are the persons that I'm serving the most, do we have translators there? Do we have intake paperwork and intake processes that can accommodate who they are and can accommodate their needs? Cultural incapacity is this stage reflects the lack of capacity in systems and organizations necessary to effectively respond to the needs and interests of diverse groups. This can include institutional or systemic biases, practices that may result in discrimination in hiring and promotion, or disproportionate allocations of resources that may benefit one group or another. This can also include subtle messages that certain groups aren't valued or welcome. That goes back to when I was talking about what does the literature look like in your waiting room? What are the pictures looking like on the walls? What material do you have in the actual care rooms where individuals are coming into those care spaces in those care facilities? Cultural blindness. This stage describes a philosophy of fairness that views and treats all people as the same. This philosophy, however, can be problematic because people are different and have different needs. People deserve approaches that acknowledge and celebrate differences while addressing these needs. Cultural blindness can in fact negatively influence systems policies by encouraging assimilation, ignoring cultural strengths, fostering institutional attitudes that blame consumers for their circumstances, and failing to hire a diverse workforce. The thing that I always go to when I talk about cultural blindness is equality versus equity. Equality is giving everybody the same thing. Equity is giving each person what they need to get to where they can. There's a picture that is pretty famous or pretty well known on the internet, that there is a game going on and there are 3 people behind a fence and they're all different heights and they need to be able to see the game. You give everybody a box the same size. The tallest person can now see over the fence. The middle person can barely see over the fence. And the shortest person still cannot see over the fence because you gave them all the same thing and they had different needs to be able to view the game. So that is equality. Equity would be to give the tallest person, who basically can almost see over the fence, give them enough to be able to see over the fence. The person that is in the middle height needs just a little bit more to be able to see over, but the person who is the shortest needs the most. A lot of times when we do fund disbursement or do programming, we say we're going to give everybody the exact same thing, but depending upon the communities that we're serving, depending upon the location of where we're providing services, depending upon the needs of those persons that we are serving, I may not need the same thing. I may need more to end up with the same result of the person that got less. So that's that cultural blindness when we talk about fairness and equality, that sometimes we can use that and it kind of causes us to move into a place that is not, that we feel is right, but not necessarily right because we're still underserving certain communities. Cultural pre-competence. This stage highlights the growing awareness of strengths and areas for improvement to respond effectively to culturally and linguistically diverse populations. I almost said linguini. I must be a little hungry, but we'll deal with that afterward. So do we have like these things in place? Sometimes we do, sometimes we don't, but we have to be able to respond to the needs of the individuals that we see, you know, whether it is culturally, whether it is about language, whether it is about literacy, whether it is about the reading levels. Am I able to read the same document that you gave to the person that came in before me or that you will give to the person behind me? Am I able to use a computer to sign in electronically? Do I have access to a mobile phone to be able to do things from my mobile device, or to download apps for your clinic? Like, am I able to do those things? Do I have access to those things? Cultural competence. Cultural competence, so in this stage, is the acceptance and respect for culture becomes consistently demonstrated in policies, structures, practices, and attitudes. This can include an organization's commitment to human and civil rights, hiring practices that reflect the diverse workforce, and increased efforts to improve service delivery of racial, ethnic, and cultural groups. That is cultural competence. Cultural proficiency, this is stage 6. And again, to get access to this, SAMHSA has it on their website. SAMHSA has more information about it if you wanted to do a little more study, do a little more research, and look it up more. This can be found through SAMHSA. So cultural proficiency in stage 6, culture is held in high esteem and is used as a foundation to guide all endeavors. Organizations that do this successfully continue to add to their knowledge base. They support and mentor other organizations seeking to improve their cultural competence, and they advocate with and on behalf of populations who are traditionally underserved or not served at all. They also partner with other diverse constituency groups to help reduce and eventually eliminate racial and ethnic disparities. Cultural proficiency is the end goal, but a lot of times we actually need to try to get to cultural competence first, and cultural competence with a splash of humility. When we talk about cultural competence is it's really around a skill set. It's around acquiring a certain amount of knowledge. It's about being aware. It's around, like, I know that this pertains to this, and to do this, I'm going to need this. It is a skill set. It is awareness. It is a knowledge base. Cultural humility, on the other hand, is not necessarily just a knowledge base to be able to say, I went through this module 1, module 2, module 3, and I passed all of the things with flying colors, so now I'm culturally competent. Cultural humility is a willingness to suspend what you know or what you think you know about a person based on generalizations about their culture. It focuses on self-humility rather than achieving a state of knowledge or awareness. Cultural humility says, while I know this about a certain population, while I know this about a certain group of people, I understand that while I know this about them as a group, when an individual from this group comes in, I have to suspend what I know. I suspend it, not meaning get rid of it, but kind of put it on the back burner and deal with the individual versus taking the knowledge. Because I took a training on how to provide care to trans women of color does not mean I'm going to be able to take that training and treat every trans woman the exact same because the training said I passed with flying colors. Humility says, while I have this skill set, while I have this competence, I also know that I have to still be moldable. I have to still be bendable. I have to still be flexible, and to say, yes, I know this about this community, but I didn't know this about this individual person. Humility puts you in a posture that you are ever learning. Humility puts you in a posture where you are not afraid to ask questions, to say, yes, this is what I know about said group of trans women. However, I understand that you are an individual trans woman who is a part of a larger community. How can I best understand your needs today? How can I best understand the bad experiences that you've had so that we can make sure that those experiences are not repeated when you come into our facility? Competence is a skill set. It's a knowledge base. It's an awareness. Humility is the willingness to be teachable, to be moldable, and to not treat everybody the same. It is the ability to move and to navigate into systems, into spaces with individuals. And it goes back to what we talked about earlier of building that rapport, building that relationship, humanizing individuals, humanizing people's experiences, validating who people are so that you can ultimately move into the space to be able to serve them properly, to be able to serve them adequately, and to be able to serve them wholly. This is what we do when we provide culturally competent and we talk about culturally competent and humble care delivery. While everybody shows up and a lot of them are similar, they are still different people. There are still different narratives and different stories. So it becomes our responsibility to kind of talk through what that is, what that looks like, how does that work. Yes, go through the trainings to learn about being culturally competent. Yes, go through the trainings about not being stigmatized. Yes, go through the trainings that talk to you about how to serve individual demographics or individual groups of people or individual groups of folk. Go through the trainings about what is gender, what is trans, what is gender nonconforming. Go through those trainings, but also still go into spaces with the knowledge that I have this base to stand on, because that shows that you have a real intention to provide culturally competent and humble care, because you've taken the time to go through these trainings and to learn these trainings. But then also go the extra step to then individualize the person. Go through the extra step to kind of talk through the person. Take the training, become competent, but do not allow those competencies to be the sole leading force of how you're navigating the client experience, of how you're navigating the patient experience, of how you're navigating how they show up, how they don't show up, how you show up, because it is more than just book knowledge. It is about human interaction. It is why we say, instead of saying someone is HIV positive, we say persons living with HIV. Instead, why we don't call people out their name when they use drugs, a person who uses drugs. You know, it's person first language. It is people first language. It is humanizing a language to create an experience, to create a space that they feel comfortable, to create a partnership in that individual's healthcare journey. And it's uncomfortable sometimes. It takes a lot of time to navigate, and we won't get it all. Like, I work on the ground a lot of times with people all the time and have for almost the last 10 years, and language continues to evolve. How we refer to individuals continue to evolve. What people refer to themselves as continue to evolve. And I could become frustrated, but does me becoming frustrated help to better serve those persons? Or does me being humble and being in a posture to continue to learn, to continue to adjust, make it the client experience better? It is about asking somebody their preferred pronouns, not looking at somebody's physical makeup and assuming that because they present as a man in your eye, that their pronouns are he, him, and his. They could be gender nonconforming and they be they, them, theirs. We have to be cognizant that how persons show up now does not necessarily equate to their gender identity. And those are little things that seem like a whole lot, saying HIV infected versus saying a person living with HIV. Those seem like little things, and they say, well, these are medical terms. This is how we talk. But when that language is communicated to a person living with HIV, it can become stigmatized. It can sound judgmental to them. It can make them feel as if you're not for them. You're not a part of their team. So it's about that important language. It's about being flexible. It's about being bendable. It's about being moldable. It's about being teachable. And when you show that you are teachable, 9 times out of 10, that client, that patient is going to show themselves to be more flexible, to be more teachable, to be more adherent, to be more keep their appointments, to enjoy coming into their appointments versus dreading coming into their appointments. And it also helps them to share that I went to Center X and they honored who I was. They really were thoughtful and intentional around the care that they gave me. Because a lot of times we have so many bad names. People have one bad experience and they go out and tell everybody this is a horrible place. And we're like, why did you do that? This is one experience. But what we have to realize as care providers, one bad experience or one experience to where we dismissed somebody or did not were not intentional on how we treated them or acknowledged how they wanted to be treated, can be that one experience that caused someone to fall out of care. Could be that one experience that caused someone to never come back to your facility. Could be that one experience that caused someone to not only fall out of care, but become non-compliant or not adhere to their medical regimen. So it's just about being thoughtful. It's about being intentional. Right here is the action plan. So an action plan. Take time and think about the who, the what, the where, the how. We need to build action plans around like what needs to happen in our facility. And these are some times that like maybe you can include it in some of your staff meetings, or maybe a 15-minute discussion around what are some of the areas of concern that we have in our agency? What are some of our areas, and I don't like to say weaknesses, but what are some of our opportunities, or what are some of the areas that we can become better, like, and have those. So what needs to happen concerning this area? Who needs to lead the action? Who else is involved? Like, what is the time frame? Something as simple as talking about, like I mentioned multiple times, like what do people see in the lobby? Like, does what they see reflect who they are? The magazine, do you serve a mostly Latino, Latina, Latinx population, but all of your literature and the pictures on the wall are African American people? Like that, little things like that, making people feel more welcome. So take time and kind of talk through those things, look through those things, kind of feel your way through those things, create action plans, be mindful of the language that you use, be mindful of the experience that you have, humanize folk, make people feel like they're a partner in their healthcare journey. Don't have people feeling like you're doing them a favor or that you're providing them a service that you don't have to. Be a partner. Be someone who shows that you're in a posture of learning, so that the person that you're serving also can take on that posture. A lot of times the people that we're serving come in with their defenses up because of bad experiences, because of lived experiences, because of stories, because of horror stories that they've heard from other folks. And we have to be mindful that every person that comes in has a story. They have lots of outside forces that they're working against, whether it is family, whether it's community, whether it's employment, whether it is the policies that are being created. And when they come into us as healthcare providers, and they come into us as persons that are supposed to help them on their care continuum or their care journey, we should not add to those negative experiences. We should not add to those experiences that cause them to feel bad or to look down on themselves. And then also, finally, I like to, there's also a responsibility that the client has to also create those environments to where we feel comfortable in those rooms. But we also have to realize, is it that I don't feel comfortable, or it's not, I don't want to take the time to be intentional around providing culturally appropriate and non-stigmatizing care. So that is my spiel so far. That was a general overview of the project of cultural humility and cultural competence. I know I've said a whole lot. Hopefully it made sense. Again, if you want more information, I can share my email. You can also go to our website, southernaidscoalition.org, to look at the trainings, to request the trainings. I'm the Senior Manager of Capacity Building. You can email me, call me, etc. And we can talk a little bit more about that. I would love to share this with some of you all in person, if possible, particularly those of you that may be in the Southern United States, so that we can go through some of the activity and some of the assimilation, so that we can really take on and embody what we're talking about, so we can feel some of those experiences, what they're like, what they look like, how they show up. So I appreciate your time. Thank you so very much. I'm going to turn it back over to my colleagues.
Thank you, Marcus. Thank you for this thorough and enlightening conversation. Thank you so much. It's been such a pleasure to hear what you have already said in regards to cultural competence and cultural humility. We are going to move, and before we get started, before we continue to the Q&A, just let me give you a couple of reminders. Session 2 of this webinar series will be on February the 24th, again from 1 p.m. to 2:15 p.m. And visit our website nchph.org, and you will find information on these presentations, upcoming activities, and information on the national conference that we are planning to host in the month of June. So if you would like to ask a question to Matt Records, please submit it through the question box on your control panel. And if you dial in through your telephone and would like to verbally ask a question, use the raise hand icon and your line will be unmuted. Any questions in the queue?
Not yet.
No yet? Okay. Again, please do not forget the post-survey questions. That information is very helpful. It will be shared with the Southern AIDS Coalition so we can improve our training, our technical assistant activities. You can visit our website. You will find information on the 2020 Health in Public Housing National Training Symposium. It will take place in Alexandria, Virginia, June 18th and June 19th, 2020. You can also join our mailing list and receive HRSA updates, Medicare updates, information on funding opportunities, and information on resources and services provided by the National Center for Health in Public Housing, and information on upcoming webinars.
Dr. Leon, sorry to interrupt you. We do have 2 questions right now.
Okay, please.
So we have one from Jacqueline Chandler. Are there template organization policies that can support centering the patient with cultural humility? I believe that would be a question for Mardrakas.
Okay, so the question, if I'm correct, are there templates for organizations to model after that would help to create culturally?
Yes, that can support centering the patient with cultural humility.
I don't know of any templates right off, but I do have a plethora of resources or sites around cultural humility and how to create being more culturally competent and more culturally humble. That could potentially just give you more feedback. So a lot of times when talking about policies of organizations, it can be difficult to completely change a policy, but also we can revisit the language of that policy. We can revisit how some things are said. We can revisit if it's inclusive language or if it's exclusive language. So I don't know specifically of any particular templates to help do that, but I do know that there's a plethora of information that can be shared that could help to inform creating policy that is more culturally appropriate and more and non-stigmatizing. And another piece of that would be to, as you build this policy and talk this policy, maybe have a focus group or a smaller controlled group of individuals that represent the populations of folk that the people that you are serving, to help also to inform and to give feedback on those policies as you begin to create them and reword them. Because again, as mentioned earlier, sometimes we will create things with great intentions and good intentions, and we can still miss them because we did not include those persons that the policies were intended to impact. So that is my answer. I don't know any templates particularly, but there are lots of resources that can be shared to help you inform some of the language around cultural competence and cultural humility.
Okay, and she said, thank you very much. And we have another question from Barbara Kosakov. A clinic has not demonstrated cultural competence but made improvements. How do they promote the change to re-engage patients they lost?
Read it for me one more time.
Yes. If a clinic has not demonstrated cultural competence but made improvements, how would they promote the change to re-engage patients they lost?
So my initial thought would be would be actually because people are not coming to the clinic because they were lost, it is now, where are those persons? Are there communities that they're in? Are there faith facilities that they're in? How now you should be a strategy of how do you take these better services that may not be the best just yet, and show folk in the community, like, let's show that we're willing to go into the community, that we're willing to do whatever the service may be, particularly HIV, like bringing mobile units to make care more easily accessible. Also identifying champions within your care facilities. And a champion is somebody who is a model client, an ideal client, but also an influencer or a gatekeeper or someone that people in the community listens to talk about, hey, we're heading up these changes. We're kind of moving the needle on some of these. We know there have been bad experiences, but I can attest as somebody who's continuing to go, that they're striving, they're making strides. A lot of times is folk know that you're intentional and trying to make strides to become better, to do better. The right person carrying the message is sometimes most important. Sometimes it may not be the provider carrying the message that we're doing better, that we've done better. It needs to be someone that the community or the population you're serving can identify with to carry the message and say, hey, they're doing better, because that community sometimes can identify better with someone that they feel is on their level. And when I say level, I'm doing air quotes. So yeah, just being unique, being creative, going into community, providing some of those easier services within the communities that you may not have that level of trust with, and then identifying a champion or someone who looks like represents the population that you are serving to actually be a spokesperson to say that, to advocate that you all are intentional about making change, intentional about becoming better.
All right, thank you so much. So far, we don't have any additional questions.
Awesome, thank you all. This has been wonderful.
Thank you so much. And if you have any questions, please contact us. These are the contact information for our staff. And if you have any additional questions that you couldn't ask Marcus, please feel free to send it to us, and we are going to make sure that he receives those questions and you get an answer from him. One more time, thank you so much for your participation. Have a great afternoon.